It gives me great pleasure now to introduce my colleague, Retsef Levi, Professor of Operations Management at Sloan. Retsef, admittedly, is probably the key driver behind a lot of the health research that's been going on at Sloan over the past few years. He's involved in all kinds of research with the FDA, with academic medical centers, with big pharma. He's really touching every aspect of health out there. So please join me in welcoming Professor Levi.
Thank you, Janet, and again, thank you, everybody. So today, I want to talk about two major aspects that are very fundamental to the discussion around health, which is cost and quality. So I think that there is a triangle. The discussion on health is kind of guided by the tension of the triangle between access, cost, and quality. And the hope is that the healthcare reform is going to solve the access issue, although it's fair to say that just the mere fact that people have insurance doesn't mean that they have appropriate access to care or to health. But the focus, after the healthcare reform, the focus has been about the trade-off between cost and quality. And what I want to start my talk today by making maybe a somewhat provocative claim that if I think about cost and the discussion about cost, if you listen carefully to the discussion, a lot of the time, or most of the time, the discussion is not about cost, but about charges, not about the true cost of delivering care or managing health. And we already heard that 30% of this is probably a waste. It's hard to identify what it is. And I would argue that potentially one of the reasons why it's so hard is because it's not clear that health organizations have a clear understanding of what the cost is. Now, if I talk about quality, again, people probably know about the assessment that 100,000 people die every year in hospitals throughout the US from avoidable errors. And if you think about the quality efforts in the US, I want to kind of talk through some of the milestones. So it's fair to say that 2000 was or 1999, where the fundamental report to err is human by the Institute of Medicine put the quality issue at the center of the public debate and as well as the center of the discussion within the health industry. So that was the first time where this was explicitly put in front of the industry as a problem, as a big problem, was an attempt to quantify the issue. Another very important milestone was the effort that was initiated by Don Berwick and the Institute for Healthcare System Improvement, which is called the 100K or 5 million life campaign, where the goal was to really save all of these lives by extensive organizational efforts with frontline people through continuous improvement. Some success stories, and maybe the most notable success story is the use of checklists initiated by Peter Pronovost and intensivists in the ICU in Johns Hopkins, who showed how if you use the idea of checklists that was used in other industries, you can actually reduce the incidence of central line infection in ICUs, something that caused a lot of mortality and a lot of cost, dramatically just by following simple checklist by the clinical care team. Now, since then, it's fair to say that the checklist has become kind of the drug for everything when it comes to safety in healthcare environments. It's fair to say that if you look now on most healthcare environments, you will have not one checklist, not two checklists, you can have tens of checklists sometimes. And in fact, sometimes every problem that emerges, people say, let's just develop another checklist for that problem. And it's also fair to say that the way we measure currently safety is through following the frequency of a few harms. For example, if you look on intensive care units, usually you will compare different units in different hospitals by looking on the frequency of maybe 5 or 6 harms. And I'm not here to dismiss that approach, but I want to also point out some maybe problematic aspects of this approach. So one problematic aspect of this approach is that when you start to count frequency of harms, you usually know that you have a problem after it happened, when there are already events. So it's by definition a lagging indicator. But the other thing is that it's nice to think about checklists if you have few events that you want to, a few harms that you want to think about. But the problem is, and I hope to show it through data, the problem is that what about all the other stuff that is happening? All of these small things, small incidents, more harms that are happening. If you start now to develop a checklist for each one of them, you're going to end up with overly complex system that is simply not manageable by humans. So what I want to discuss with you today, one of the pieces of work that I want to discuss with you is work that we are doing in collaboration with Beth Israel Deaconess Medical Center. It's one of the academic medical centers in the Boston area. It's a project that is funded by the Moore Foundation, and it's about trying to develop a new approach to safety, specifically starting with the ICU, with the hope that this is something that will be transferable to other care environments. And this is joint work that is being done primarily by students at Sloan, and here are the names, as well as a big team of clinicians and staff at the BIDMC. So what are the major ideas, what are the major new ideas in our approach to safety? There are two core ideas. The first idea that we really want to go beyond measuring specific frequencies or specific harms. We actually want to develop an aggregated notion of what we call the total burden of harm. And I'm going to make this more explicit in just a bit. What is the advantage of this? We actually believe that this is capturing a much more accurate picture of the safety level of the environment, but moreover, it provides you potentially a statistical power to actually find causalities of what drives harm, and then potentially develop interventions that are actually much more systematic than the ad hoc checklist that you might want to develop for a specific harm. The other idea is really thinking not on one specific patient, not on one specific harm, but actually thinking about fundamental environmental and system risk states that seem to actually drive the likelihood of harm higher. So what conditions of the system, the people in the system and the environment of the system are more latent or more likely to lead to harms of different kinds. And then we want to use statistical methods to actually make connections between the two. What conditions connect to which harms? And hopefully that will lead ultimately to different kinds of interventions, monitoring, control, and systematic changes in the environment that prevents the system to arrive at those risky states, and in that way actually reduce the overall harm in the system. So let me try and make these ideas a little bit more concrete. What you see here is our approach to actually measuring the total burden of harm in the ICU environment. So what you see here on the upper left-hand side, there are 6 harms. These are exactly the traditional harms that you would measure currently in most ICUs across the country. For example, you want to know what is the frequency when a patient is ventilated, what is the frequency that this patient will develop an acquired infection because of the ventilation, right? If you have central line, what is the frequency of infection because of the central line? So this is being measured, and most systems, especially the good ones, invested a lot of effort to actually get better at this and reduce the frequency to the minimum, and did quite well on that. The second bucket of things here, you see things that are being reported and documented within BIDMC in the reporting system, different incidents that are being reported. The hospitals today are obliged to have reporting systems, internal reporting systems that allow staff to actually report on incidents. But I think that the most exciting part is actually something on the right. So what we did on the right here, we took something that was initially developed by IHI, which was a tool to actually look on very selective number of cases, looking manually through the medical record and identify different harms that happen to the patient. What do I mean by that? So for example, if you look here on, if your glucose level goes below 50 while you're on insulin, that means that something in your care did not go as planned. So we're going to consider that as a harm to the patient, although potentially nothing nothing that the patient will suffer throughout, nothing happened that the patient will suffer any long-term consequences to the patient. Nevertheless, we're actually going to consider that as a harm. Did we oversedate the patient? Again, most of these harms not necessarily lead to something that is a long-term impact on the patient, but we actually believe that this is the right way to measure the overall mistakes and errors that happen in the environment. And moreover, instead of doing it for 20 cases manually, we are now able to do it in an automated way for all the patients over 3 years or 5 years or whatever years you want. We started with 2 years, but we can do that in an automated way. So we now have the ability to actually measure the burden of harm for every unit in the hospital, for every shift over a long period of time. And let me show you some of the insights that emerge. So for example, if I just look on traditionally harms here on the left here, what is the frequency per shifts, right? What fraction of the shifts do you have harm among the harms that you measure currently? You get something very small, like 2%, 1% of the shifts, right? However, if you look on the overall burden of harms, you actually get to something close to 30% of the shifts. What is the lesson of this? The lesson of this is that we actually don't capture a lot of the bad stuff that has happened by just looking on 5 or 6 things. We really have to look at it in a more aggregated way, because otherwise we are going to miss a lot of the problems, safety issues, problems that we have in our system. We can also look on specific sets of harms. So for example, what do I mean by instance harm? These are harms that happen in one shift. We know that the error was confined to one shift. Someone made a mistake in that shift. On the other hand, there are harms like if someone got infection in their, because they are ventilated, you don't know exactly when this harm happens. It's probably something that could have evolved over multiple shifts. We call that evolving shift. So you can actually think now about classifying and aggregating in different ways harms in a way that actually teaches you different things about the environment and about what is the true state of the safety level in your environment. Okay, and another thing is that if you just look on the traditional harms, basically, every 1 in 100 patients has been affected. If you look on the aggregated burden of harms, basically every 4 patients. So it's times 4-fold higher level of harm than if you just look on traditional harms. Okay, so now I want to talk about the second idea. So the second idea is really thinking about these environmental states. Okay, what do we mean by that? We call these risk drivers. So these are conditions or states of the ICU environment, the system of the ICU, and the people in the system that increase the likelihood of harms. Right? And the fundamental assumption is that these states are actually common to many, if not all, harms. It's not that each specific harm has its own specific causes. That might be true, but we also believe that there are fundamental conditions that actually increase the likelihood of harm, whatever that harm is, right? Under this assumption, we were able to come up with the hypothesized sets of drivers, of conditions of the ICU, and we chose to focus not on one specific patient, but to focus on a unit. In academic medical centers, you have multiple ICUs, so a unit is, let's say, the cardiac ICU, the medical ICU, the surgical ICU, and we also decided to focus on a shift, right? And for each shift and each unit over multiple years, we are able to identify different parameters that we believe are capturing the state of that unit and that shift. So for example, we're going to talk about how many patients that were readmitted are currently in the unit, how many new admissions are in the unit, what is the level of experience of the nurses in the unit at that moment, how many patients that are boarding, how many patients that are not supposed to be in that ICU but were placed in that ICU because of capacity problems, right? How many nurses are boarding, how many nurses that usually work in another unit are currently working in this unit for this shift because, again, staffing issues, right? And again, this is not a final list, this is a starting list. It allows you, the model allows you to essentially add more and more hypotheses about what do you think is driving harm in your system. Now, how do we come up with this list? We came up with the list as a combination of what we know about how errors are being done. We know that errors are being done through 3 fundamental mechanisms. The first mechanism is that people just become absent-minded. They do the same thing again and again, and at some point they just like get sloppy, right? The second thing that we know, the second mechanism is that people are just blown by a lot of noise, a very noisy environment, and then they start to make mistakes because our brain has very limited capacity for conscious thinking. Our brain has a lot of capacity for instinctive thinking, but very little capacity of conscious thinking, right? And once you blow up the brain with too much distraction, people start to make mistakes, right? The third thing that we have, the third mechanism is people are just not competent. They just don't have the knowledge or the expertise, and they just simply make wrong decisions. So if you think about checklist is very effective only for the first mechanism. It's actually completely ineffective for the other two mechanisms. So therefore, if you just confine yourself to interventions that are around checklists, you're not going to prevent a lot of the harms, a lot of the errors that happens in the environment. Okay? So again, that was another step. And again, this is very much work in progress. I don't think that we have the comprehensive list. I hope that in a few years we will learn what is the right list. But what we're trying to do is now connect the two through some statistical analysis, because we are able to measure things throughout a long period of time, of multiple years. We can measure the burden of harm over multiple years, and can measure the state of each unit, of each shift in the hospital over multiple years in an automated way through data analysis, through the data systems of the hospital. So doing that, we're trying to find causality, as my colleague Joe Doyle just talked to you about before. But this is very challenging. Right? It's challenging for several reasons. First of all, remember, we do not look for a black box that will just say, oh, in this shift you have a higher risk. We want a descriptive tool that will tell people what are these risky states. Right? We want something that will lend itself to systematic redesign changes that will prevent the system from getting into those risky states. Right? So that's kind of one challenge. How do you aggregate the harm? How do you validate the model? Because you're actually trying to estimate, to predict something that is a relatively rare event. Nevertheless, we gave it a try, and this is just a sample result. So what you see here, that one of our models, one of our insights so far, and just one insight, but we still need to validate, is that one of the specific units in the hospital, if you are in a day shift and you have 5 or more heavy loaded patients, then suddenly the rate of the harm increases by 5 times. So if the a priori rate of these instant harms, we're not talking about instant harms, is 4%, if you're in this state, the rate goes up to 22%. Right? That's something that preempts investigation. What do we do with that? And this was not the only insight. We actually realized that overloading the nursing staff is a primary driver of actually errors and harm. So one of our attempts was research them, how do we even measure that in a constructive way that actually can lend itself to actually good decision making, right? So if you look on how nursing loading is measured, here is one way to do it. It's called the TISS score. It's essentially looking on all the things that each patient requires from the nurse, and it aggregates this, but it does it in a very retrospective way, right? So after the shift is over, I'm going to look on what the nurse did, and I'm going to count, and I'm going to say, give a score to each patient and say this was that load, that patient was this load, and I'm going to understand what is the load that was on that nurse. Question is how you translate this to something more proactive and predictive. So one thing that we did, we actually took data and we looked on one of the units, and we tried to actually look on patients and divide them into 4 categories. High load predictably, high load variably, low load that is predictable, and low load that is highly variable. What do we mean by that? We don't want to look only on the average case of a patient. We want to also understand how risky that patient is in terms of suddenly becoming a very high load patient, although maybe on an average this patient is actually not as high load. And in fact, what you get here, I'm not going to get into this, you get that most of the patients are actually highly predictable. Only a few of the patients are highly variable, right? So that already gives you a predictive insight of understanding that different types of patients, it's not only about their nominal load, it's actually about what is the likelihood that they suddenly will become a big problem that suddenly will employ a big load on the nursing staff or the clinical care team in the ICU. The other thing that we kind of was a striking insight was, so nurses are usually assigned to patient by regulation, either at the 1-to-1 ratio, which means the nurse is responsible for one patient, or at the 1-to-2, where the nurse is responsible for 2 patients. Now, you would imagine that the intuition would be, I'm going to assign the heavy loaded patients to nurses one-on-one, and I'm going to take the easier patients and assign them 1-to-2 to nurses, right? That's kind of, and that's indeed the intuition that guides how people in ICUs are staffing currently and doing the assignment before the shift starts. But the data suggests actually that 1-to-2 nurses are actually much more loaded than 1-to-1 patients. And in fact, this is even worse because think about it, the 1-to-2 nurse is not only having a higher aggregated load, it actually has to split its attention across 2 patients, which actually adds another level of complexity beyond just the aggregated load. Okay? So what was our solution to this? We actually employed ideas from what we know about process flexibility, something that in operations management, in supply chain management, we actually studied quite a lot. And we actually were able to come up with a scheme that instead of just staying with the traditional 1-to-1, 1-to-2 staffing, you have to keep that because of regulation, I'm going to take it to another step, and I'm going to actually assign nurses to each other as a backup to each other. And there are different ways you can do that. And what we showed that if you do that in a smart way, we actually showed it on data. So if you look on the current state, that's the first row, 500 nurses over the course of 2 years ended up being overloaded with respect to some threshold. If you just do this simple assignment of backup assignment, you can actually reduce it to about by more than 50%. In fact, by 75% to about 100. And that's even without trying to optimize it even further. I actually believe we can actually get better than that. This is something we are actually going to pilot as a new scheme of how to staff in the ICU. And I believe that this is really something that is going to be the kind of interventions exactly one envisioning when the systematic interventions that I would envision that address risk or harm in a much more fundamental way by actually making the system fundamentally better. Not just by adding to it more and more checklists that makes it more complex, but really making it fundamentally better and more robust. Not only to one harm, but actually to a range of harms. Okay, so that's kind of the first thing. There are many next steps that we need to take. I want to quickly go over the cost issue. And that's another project with Beth Israel Deaconess Medical Center, where the issue that we had to approach was how to deploy surgical services over a network of locations within a health network, where the network in this case consists of the one academic medical center in the Boston area and 2 community hospitals that were acquired recently by the hospital. We were talking about 57 surgical procedures across 3 service lines. And this is a typical problem that many networks currently have to face, not only about surgical service, because you have to get to the community, you have to manage populations, you really need to think about how you deploy resources across your network, okay? And in this particular case, there were 2 major issues. One of them is what we call leak demand. A lot of the patients that were supposed to be handled by the network actually ended up getting care outside the network, which is a big problem if you are under risk contracts or you are actually paying extra for those patients. And moreover, there was an imbalance of how you would use the resources between the academic medical center that was overly utilized and the community hospitals that were underutilized. Now, how typically healthcare systems think about cost? They think about cost in the following way. So let's say that they want to estimate the cost of a surgery. They were going to take all the variable costs that you see here on the left. They're going to account all the tests, all the drugs, everything that you need to do for this. And then they will add to this some allocation of what they call the fixed cost, which is how many hours the surgeon had to do the surgery, what is the salary of a surgeon. I'm going to do a calculation and say how much I pay for an hour per surgeon. I'm going to allocate that to this activity. So the overall cost that is being associated with the procedure will be the variable cost plus the allocated fixed cost. That includes the labor cost and the overhead cost. And this is, to me, a big issue, a big problem of understanding the true cost, because the one thing that it misses the understanding of what we call the opportunity cost, which comes from the fact that you have to take scarce resources and allocate and make trade-offs by allocating them to potentially different activities. So by doing one thing, you need to understand what other things you are not going to do because of that, because that consumes the same set of resources. You cannot see that when you do this kind of cost accounting. This is something actually that is common to all the healthcare networks that I've seen. What are we proposing instead is an optimization-driven approach that actually is inspired by what techniques that are being used in the airline industry, where essentially we model the network as a collection of locations and resources that some of them are flexible, you can actually allocate them across the network, and a set of procedures that consume resources and have some demand and potentially some revenues and costs, but the costs that we account for are only the variable cost. We essentially capture the fixed cost that I talked about that is traditionally allocated to activities by capturing the capacities in the network. What capacities exist in the network, and how now I'm allocating activities across the network in the context of what I call a welfare objective. What do I mean by welfare objective? I don't try to do the best thing for every patient. I always tell doctors that if you try to do the best thing for every patient, you are guaranteed not to do the best thing for every patient, because you have scarce resources. It forces you to make thoughtful trade-offs and really think about what is overall good that you want to have for your entire set of population of patients. And you can think about revenues, profits, utilization, access. You can choose that, and the model is robust to allow you whatever choice of objectives you want. So let me just end up with some surprising insights that come from this. So what you see here, these are the 57 procedures that we talked about, ranked based on the perception of the hospital of what is currently most profitable for them. And what you see here, rectangles are what we want to do in the community center, and the blue diamonds is what we want to do in the academic medical center. If it's up, it means that we want to increase it, the volume. If it's down, it means that we want to decrease the volume. If it's flat, we want to keep it the same. And surprisingly, we actually recommend to move some of the most profitable procedures from the academic medical center to the communities. And why do we suggest to do that? Is because although based on what they think they're most profitable, in fact, these procedures consume far more resources than the average procedure. And in fact, by doing them in the academic medical centers, you block and prevent many other activities that you could have done and will give you actually overall better value. Okay? So by this, I want to finish and just open up for discussions. For questions. Yes, thank you. Yes.
Good afternoon. Thank you for the stimulating talk. I'm Neil Wasserman from Time Wave Analytics. One consideration that emerged from your discussion was that the model that you're applying to reducing errors in the hospital environment, you could call that adherence to recommended practice for the professional staff. And the same model might apply to patient adherence. That is, some of the lessons that you've learned from creating a social model, distribution of attention, allocation of resources, could also be applied to patient adherence, and I'd be happy to talk about that with you. Patient adherence is the area of my focus. The other thing that might be useful to think about is to apply some of the lessons from patient adherence to the subject area that you're addressing, namely the desirability of creating social connections among adherent members of the community and synchronous events to provide synchronous feedback loops in terms of correcting operations within the environment. So I'm just suggesting that both areas of application could learn from each other.
Yeah, I think that the idea of trying to see how it applies to patients is a great idea. One thing, you mentioned social networks. One thing that we still don't capture here, which I think is a big driver of harm and risk, is the communication, quality of communications. The reason why we don't capture it is very hard to measure, but I do hope that we're gonna have now the technology soon to actually measure the map of communications between the different teams and the different locations in a way that will allow us to actually quantify how much that plays a role in harms. I can tell you that from looking on debriefs of medical errors, in almost any one of them, communication breakage was one of the major aspects that play a role there. So I think we really want to get to a place where we can actually measure this in a much more accurate way. So far, we are limited in how we can measure that. Yes, more questions. This is the back there.
That are likely to suffer from harm by looking at staffing levels or past admissions of the patient? Could you go back a day, a week, a month? So to allow for hospitals to plan for a population that's likely to cause harm. Be harmed.
In this work, we are not trying to predict the risk for a specific patient. In this work, we're trying to say to the system, these are the states where you are in high risk of harm. Try to avoid those states. We're not trying to predict when a risk will happen. We're not trying to say, for this patient, it's more likely that the risk will happen. We're trying to say what environmental states are going to be predictive of higher likelihood of harm. Let's just try to build the mechanism to avoid those states. Okay? Yeah. I think I'm out of time, so I'm happy to engage with others offline. Thank you very much.